All right, it is 1 o'clock, so we will get started. Good afternoon, everyone. The APIC Great Lakes chapter is once again pleased to welcome you back for another educational webinar. My name is Chao Win. I'm joined today by my colleagues Kelsey and Denise. We are the education team for APIC Great Lakes, and we have had the pleasure of collaborating with Dr. David Heyman to put on today's event. Our session today is titled Health Security, Changing Perceptions Over Time. And then just a few housekeeping announcements before we begin. If you can mute your line to minimize background noise, that would be great. And then drop any questions you have during the conversation in the chat, and then we will circle back to them at the end of the presentation. Today's presentation will be recorded and slides will be made available. CE is not provided for this webinar. And with that, I'm pleased to introduce today's speaker, Dr. David Heyman. David Heyman is a medical doctor and epidemiologist and professor of infectious disease epidemiology at the London School of Hygiene and Tropical Medicine. From 1989 to 2009, he held various leadership positions in infectious diseases at the World Health Organization, including polio eradication, and in 2003 headed the World Health Organization global response to SARS in his role as Executive Director of Communicable Diseases. In 1976, after spending 2 years working in India on smallpox eradication, he was a member of the CDC team to investigate the first Ebola outbreak in the DRC and stayed on in sub-Saharan Africa for 13 years in various field research positions on Ebola, monkeypox, Lassa fever, malaria, and other tropical diseases, after which he was seconded by CDC to the World Health Organization. He has published over 275 peer-reviewed articles and book chapters, is editor of the Control of Communicable Diseases Manual, and is an elected member of the UK Academy of Medical Sciences and the US National Academy of Medicine. And with that, Dr. Heyman, the floor is all yours. Welcome.
Thanks very much, Chow, and thanks to all of you for tuning in today. I'm really pleased to be able to speak with you about changing perceptions in global health, because it's something that we understand as public health leaders, but that our political leaders often don't understand. And public health is a really vital part of our life every day, as well as very important for emerging infections. And as you know, emerging infections are those infections that cross the species barrier between animals and humans and are found in humans. Actually, if you think about it, humans are really the sentinel population for many of these infections that occur in animals. And here you can see in the middle the animals that have infected humans with various infectious organisms, usually virus. Now, when there's an emergence, there are actually 3 different pathways that emergence can take. One is no further transmission. And if we were in the room, I'd ask for you to shout out what you think that might be. And in short, it's a disease like rabies. It emerges, it infects a human, it doesn't go further. Then there are those emergents which continue transmission for a time, then they cease, become sporadic. And good examples of this are H5N1 right now in the US and other places where there are a couple people infected now and then it goes back into nature, or the Ebola outbreaks in West Africa. And finally, then there's those that continue transmission and become endemic. And we've seen HIV last century. This century, we've already seen COVID-19. So these are the 3 general pathways of emergence. And when they emerge into a world that is increasing in travel, especially by air, and increasing in the numbers of countries that are participating in that travel by air, making it possible to spread infections around the world. And that is what happens today, as we know from the COVID-19 pandemic. Now, emerging infections are important because they cause illness, they cause death, but they also cost economies a lot of money. And as you can see here, swine flu H1N1 worldwide is thought to have cost between 45 and 55 billion. But if you look at COVID-19, it's cost the world 11 trillion in 2020. So these are very important infectious diseases, not only from the point of view of illness and death, but also to economies. I'm just going to briefly review with you the human coronaviruses that have infected humans, since at least these are the ones we know about. There are 4 at the top that are endemic. These are seasonal coronaviruses that cause the common cold. They peak in the winter, early spring. They cause mild disease, upper respiratory tract infections. Elderly are hit the most, and these infections don't cause sterilizing immunity. You can be reinfected from any one of these viruses. Then there have been 3 viruses that have emerged in this current century: 2003, 2012, and 2019. Now, in 2003, it's pretty well understood that this virus, SARS coronavirus 1, came from animals in a live animal market. And some of the animals in the chains of transmission were civet cats that you can see here, or raccoon dogs, but they came from nature, probably from a bat. And this was a new virus, and it was a one-time mutation. There is probably only one source of this somewhere in a human or an animal that had a mutation that was able to spread. And this infection did spread. What you can see here is that it began in November in China, in the Guangdong province, around the 15th of November in 2002. What you can also see in this graph is the light gray bars, which represent health workers. And this is a common factor of emerging infections. Health workers become infected, they don't know they're infected, and they drive the outbreak into the community, into their families, and amplify transmission in communities inadvertently. And this is just what happened in this outbreak. You can see that around December 13th, health workers began to get infected. Then there was a major group of health workers who became infected. And in late February, one of those health workers, a doctor from the Guangdong province, came into a hotel in Hong Kong. And many of you will remember this. This was a doctor who had been treating patients in Hong Kong. He was one of those on the gray bars of patients, came into a hotel in Hong Kong, and from that hotel stayed one night in the room that's green. In the room that is blue, all these different rooms that are blue, where there were people who returned to their home countries infected with something that the person in room K had. And what you can see also is some red dots on this. Those reds represent where there was those reds represent where there was PCR fragments found on the carpets in front of the lifts and in front of the room where that patient stayed. This was only known after the virus was identified in Hong Kong as being a coronavirus. Now, these are the people in the blue rooms, and you can see where they went. They went around the world. And in fact, they went into Singapore, US, Ireland, Canada, Hong Kong, other parts of Hong Kong, Vietnam, and then into Bangkok. And this was a major outbreak. It was an outbreak that had not so many cases, 8,000 or so cases with about a 10% case fatality rate. But what was important about this is that this finally sensitized our political leaders of the importance of infectious disease outbreaks and the fact that they could spread around the world. This disease did not become endemic. SARS coronavirus was a one-time mutation event. It's now gone from human populations as far as we understand, but it is present in laboratories, and the last human cases were accidents in Singapore, Taiwan, and China. MERS coronavirus, another coronavirus, emerged in 2012. We know that this virus is carried by camels. It's carried in their nasal passage, and they don't become ill. And this shows you a farmer farming his camels in the Middle East. This led to an outbreak first among farmers who then took it home and infected a few people in their household. And if they were hospitalized, a few people in the household got infected. But this coronavirus, unlike SARS coronavirus 1, did not spread easily from human to human. It did spread, however, internationally, and this shows how it spread the pathways early when it was first identified. And this is how it spread in a hospital with poor infection control. In fact, health workers in this hospital in South Korea were treating a patient who came in from Saudi Arabia, number one. Three of those, the patient went to three different health facilities and was treated in each of those health facilities. And then in turn, people from those facilities went elsewhere and caused an outbreak of over 200 people and 30 some deaths. We know that this disease doesn't spread easily from person to person, but it does spread easily when infection prevention and control is not up to standard in hospitals, as occurred in South Korea. This is where the virus has gone since 2012 when it was first identified. And what you can see here is not only camels infected in the Middle East, but also in sub-Saharan Africa. And this is certainly a concern because it hasn't been noted yet that humans have been infected there, but they may be and not be detected. So this is an infection that spreads from camels to humans. Camels likely become infected from bats, or they spread it from one to another. And it spreads in healthcare-associated transmission in health facilities and close contacts in households. This infection, though, did not become endemic in humans, although it is endemic in the Middle East and in Africa in camels. And there are still occasional human infections. And then the third infection was SARS coronavirus 2, which caused COVID-19, and we all know very well what happened in that sad and tragic outbreak. This is now endemic in humans worldwide. Animal reservoirs may be developing. You'll remember that minks became infected. They were then culled, but they did transmit the infection back to humans in a different form. And there are other animals that may be susceptible and maybe will develop infection and become reservoirs in the future. So we've seen now the four endemic coronaviruses. The three coronaviruses emerged in the 21st century. And for each of these, there needs to be a risk assessment, identifying the factors that lead to their emergence, and then at the animal-human interface. And I like to use the Swiss cheese model, which many of you will know because James Reason published it in the British Medical Journal back in 2000. This model says that if you want to pass an arrow through four pieces of Swiss cheese, you must line up the holes in that Swiss cheese. In risk assessment for emerging infections, these holes are the risk factors that lead finally to emergence. And I think a very good example of this is one that occurred in Sudan in Africa back at the turn of the century. What you can see here is ruminant animals, and these animals are a major money-making agriculture in Sudan. The animals are then sent across the Red Sea to Saudi Arabia, to Yemen, to other countries, especially at times of religious sacrifice. So the ruminant animals raised in Sudan cross the Red Sea into Saudi Arabia. Now, these animals, ruminant animals in East Africa, are susceptible to an infection that most of you will know about called Rift Valley fever. Rift Valley fever is a virus. It has a sylvatic cycle in animals where it's transmitted from animal to animal with mosquitoes, Aedes mosquito. It then has a domestic cycle in domestic animals, and you can see there the ruminant animals that are of concern. And then it spreads in humans, either by the bite of a mosquito or from the blood of a ruminant animal, and blood occurs when there's a religious sacrifice. Now, fortunately, there's a vaccine that can prevent against Rift Valley fever in ruminant animals, and here it's being used in East Africa. But insufficient veterinary vaccine production occurred in the 1990s, and animals were no longer being vaccinated. Or if they were being vaccinated, it was very few who were vaccinated to take, as you'll see, legal trade across the Red Sea. Now, in East Africa at that time, there was an El Nino event. And El Nino events this was over the Indian Ocean. It warmed the Indian Ocean, it caused excessive rainfall, and as you can see, there was spreading in southern Sudan, a flooding. Now, that flooding does two things. Number one, it moves animals and humans closer together on remaining dry land. But number two, it also causes an increase in mosquitoes and mosquito breeding. So these are the second and third holes, if you would, in the Swiss cheese: flooding, mosquitoes, and the first hole being ruminant animals that were not vaccinated. As a result, there was a major outbreak of Rift Valley fever with a high mortality, 30% case fatality rate in East Africa. This is the Red Sea. This is the boats that cross it. Some of them are large commercial liners, and on them, if they take livestock across to Saudi Arabia and Yemen, the animals must have some type of a vaccination certificate. Many times these are false, sometimes they're real. But on those smaller boats, you can be guaranteed that there will be no vaccination in the animals. And those are the animals that also cross across the Red Sea into Yemen and Saudi Arabia. Two types of trade: legal, illegal. And when those animals got into Saudi Arabia, they caused a Rift Valley fever outbreak in animals in that area and also in humans. The virus is now endemic in Yemen and Saudi Arabia, as well as in Africa, in ruminant animals, and it occasionally causes outbreaks. So in this case, the Swiss cheese event was unvaccinated ruminants, flooding of an El Nino event, then animals and humans closer together, increased mosquitoes, and susceptible populations, because there is no vaccine that's being used in humans to prevent infection, and the animals were not protected either. As a result, the human Rift Valley fever outbreak occurred in Sudan and then spread internationally to Yemen and Saudi Arabia. Now, these emerging infections are the reason that the world is so concerned about its health security. And health security is not a new concept. It's been understood since the 14th century that infectious diseases spread across international borders. And back in those days, there were four major concerns and four major infectious diseases that were of concern for international spread. The back one, a general bill for this present year, shows plague being counted in 1665 in England, smallpox, cholera, and then yellow fever. The four infections that were known to spread internationally and cause great concern. Now, in the 14th century was the first time in written history that anyone tried to stop these infections from crossing borders. No one knew what caused plague. They knew, though, that if the ships that were bringing people into the country were kept out in bay for 40 days, if there was plague on those ships, the rats would be dead, as would be the humans. So the ships were quarantined. They were kept out in bay for 40 days. Then they were permitted to come in. Land crossings were the same. There was a quarantine for 40 days. It was sometimes successful, sometimes not, but they did try to control the international spread of plague in 14th century in Venice. Then in Europe and North America, in the 19th and 20th centuries, there were what were called international sanitary conferences, which are really just treaties. And this is one of those conferences held in Boston, which was talking about cholera. What this treaty says is that if any of the countries in North America or in Europe that have signed this treaty have cholera, they agree that they will send a message to the other countries that have signed the treaty that cholera exists in their country, and therefore they should quarantine people from their country if they come across the ocean or cross international borders. This was an attempt to limit the spread of infectious diseases, and it was called an International Sanitary Conference. 10 of these for 10 different diseases, or 10 of them which were renewed for diseases like yellow fever and cholera. Then in the 1920s up through 1965, in the international organizations such as the League of Nations Health Organization and then the World Health Organization, there were a set of regulations which turned into what's called the International Health Regulations. And I know you've heard of these as well, being public health workers. The International Health Regulations in 1969 had a very limited scope. They were for maximum protection against the international spread of infectious diseases with minimal interruption of travel and trade. What they were doing is trying to stop infectious diseases at borders. And so what was required is if one of these 4 diseases occurred in a country, they were to report to WHO. Just as in the 19th century, in the sanitary treaties, they were to report to the countries that signed the treaty. Back then, it was by telegram and then telex. Now it's by electronic means, digitally. But anyway, reports made. Health measures were required at the borders, and they were required to prevent vectors from proliferating. And at the same time, there could be a requirement to be vaccinated if you entered a country from a country that had reported one of these diseases. So 3 measures: notification, health measures at the border, and health measure or at the borders, as well as maximum measures such as vaccinations could be required. This is how they worked. Disease reporting was by countries to WHO. WHO publishes this each week in its weekly epidemiological record. And this was a bulletin that was sent to countries originally by telex, then by fax, and finally it's being sent each week by internet. If a country reported one of those diseases to WHO, it appeared on the back page of the record, and then the country that was receiving passengers from the country that had reported the infection could require such things as a vaccination. And if it wasn't in the international health regulations, then the country was expected to stop the spread of this infection nationally, and they could request help from WHO if they needed it. This is the weekly epidemiological record. On the back page, you can see here yellow fever, fièvre jaune, which is reported. And any country that had passengers coming from the country that reported that could then require that yellow vaccination certificate for a traveler coming into their country. This required rat guards and things at ports, spraying in airplanes. It required, in some countries, border measures to take temperatures of people coming into the countries, and quarantine, making sure that people who might have infection quarantined. This is what we imagined, or this is what at least most of us imagined at the turn of the century, at the turn of the 20th century, when border requirements to protect against the international spread of infectious diseases were thought to be enough to stop diseases. It was hoped that those border measures could stop the international spread of infectious diseases. Well, our political leaders, public health leaders, probably understood way before them, but our political leaders finally understood this in 2003 when this SARS coronavirus 1 spread around the world. And so they requested through WHO a revision of the international health regulations. This revision went from those 4 diseases, remember, cholera, plague, yellow fever, and smallpox, to all public health threats. It went from passive to proactive, using real-time surveillance and evidence. Instead of having countries report, there was a proactive way of determining what was going on globally. And it went from control at borders to detection and containment at source. A major change. The main objective remains more or less the same. It's to establish measures that protect against the interference with international travel and trade of the spread of infectious diseases. It's quite a surprising limited scope of these regulations, and they're often interpreted as being much more than that. But what the regulations in the revision did was they recommended that countries strengthen their national core capacity for surveillance and control as the major input. Remember, in 1969 regulations, it was reporting to countries and making sure that your borders could stop disease from entering. Understanding that disease could not be stopped from entering because of its incubation period and a whole series of other reasons, the new regulations require strengthening of national core capacity and surveillance. Good contact tracing, such as was done in Japan during COVID-19. They had a good surveillance system. They could detect the cases when they occurred. They then found out by investigating backwards, retrospectively, where they came from. And instead of shutting down the whole country, they shut down those areas where transmission was occurring, mainly in gyms, in nightclubs, in various places where people were gathering. They then traced forward as well, looking to see, find the people who were possibly infected and putting them under surveillance, fever surveillance, and if they developed a fever, they were put into quarantine. So these are good public health measures, and WHO requires countries to have those measures, and then there's an electronic system through which they report every year whether or not they've developed those core capacities in public health. This is recorded by WHO, and anyone can have access to this to see what a country's score is in the preparedness. Now, what happens in addition is that countries can request from WHO and a group of partners, which is called the Public Health Global Health Agenda. They can request support to strengthen their core capacities, and they can also request support to have periodic evaluation of their capacities to see what's lacking. And many countries do that, and the US was behind this through WHO, working in better times to help strengthen public health throughout the world. So after the SARS outbreak, it became clear that another component of health security has to be strong public health with detection, risk assessment, and response. Now, the international health regulations also have a safety net, and the revised regulations have mandatory reporting of a possible public health emergency of international importance. Many people call it a fake. And in addition, it has an emergency committee to advise the Director General at WHO whether an event is really a fake, and then there should be a coordinated global response. Now, this is a decision tree within the International Health Regulations of 2005 that shows what should be reported to WHO. If you follow this decision tree, and we'll do it in a minute, what happens is you come out whether and understand whether or not the disease that's occurring in your country is a potential public health emergency. Then that information goes into an event management system at WHO, and states parties, which is member countries, can have a view of this before anyone else does this. Only if they're a member of WHO and have an international health regulation focal point. The US focal point is at CDC. I don't know whether that focal point is still able to access this information or not. Certainly WHO hasn't stopped it, but it's possible that the federal government has stopped the IHR focal points in CDC. How does this work for the safety net? Well, let's go back to Zika, which you'll remember was associated with neurological disorders and microcephaly. The Brazilians had clusters of microcephaly in areas where Zika transmission was occurring, and they didn't know what was causing this, but they thought this might be a public health emergency of international concern. So they went through the decision tree. Any event that is a potential interterritorial public health concern, including those of unknown causes, should be considered. So they considered it. They then said, is there a public health impact of the event serious? And of course it was serious. Microcephaly is extremely serious. Then the question was, is it unusual or unexpected? And certainly clusters of microcephaly were unexpected. And so this became an event that was notified to the World Health Organization. When it was notified, the World Health Organization called together an emergency committee, and this is the emergency committee in Geneva. And what you can see is that Brazil, in fact, is presenting its information to that committee. The emergency committee is made up of representatives from around the world, many of them virtual. This was the present ones, but there were many others who were virtual, working to understand whether they will recommend to the WHO that this is a public health emergency. If it is, then that emergency committee must meet, usually virtually, every 3 months until they declare it's no longer an emergency. So you can see how the safety net works. Countries are expected to have core capacities to detect and respond, but they're not the only ones now that are reporting to WHO. WHO takes reports from many different risk reporting sites, as you'll see as we go on through the presentation. And then the decision tree is made to see whether it's of urgent international public health importance with an emergency committee. And if it's yes, then there has to be a collaborative risk-based public health measures identified and managed proactively by WHO. Now, this is a treaty. It's not a strong treaty. And as you know, it was not very effective during the COVID-19 pandemic. It was not in place, the revision before COVID-19, SARS coronavirus 3, but SARS coronavirus in 2003 did strike a collaborative effort where the world worked together to stop that outbreak. COVID-19 didn't do so well. But there is a strong health security network, and after the IHR, the health security must include strong public health with detection, risk assessment, and response, and the fake safety net. So already we're seeing that this changes dramatically as time goes on. The regulations are no longer just reporting, they're really acting within countries. And then we came to the West Africa Ebola outbreak and the COVID-19 pandemic. And both of these pictures are very similar because what happened in both of these countries is that the health system collapsed. In Africa, you can see empty hospital wards. The health workers were no longer available. Many of them had died from Ebola. In COVID-19, in Italy, they had to put up tents, as they did here in the UK, to take care of the excess of patients who needed intensive care. And in the US, I'm sure you all know this graph, you can see the seasonal average of death in the US in the gray, excess deaths. And then you can see the reported deaths from COVID-19 and the excess deaths above COVID-19. Many of those excess deaths could be due to the fact that people could have not obtained routine health care. And this shows you in West Africa, what you're seeing here is red is patients with malaria who would have recovered without patient care if they could have accessed it. Pink, those who would have recovered if they could have been hospitalized. And blue, deaths from increased transmission because people were not being treated. And the green and the blue is reported Ebola deaths. So you can see that as Ebola increased and then decreased, malaria increased because of the collapse of health systems. So resilient healthcare is also a health security necessity, and there must be a surge capacity and continuity of routine care. In the COVID pandemic in the US and in many other countries, COVID, the people who died or who got serious infection were mostly those with underlying health conditions. Here in the UK, at one point in time, over 80% of the COVID deaths were occurring in the obese. So who had other comorbidities as well, clearly diabetes too, and others. But you can see that healthy populations survived the infection much better than did unhealthy populations. And so in health security after COVID-19, we also need to make sure that our populations are healthy so that they can resist serious outcomes from infection. And that's a big job, especially in the US and in Europe, where projections of comorbidities and obesity are increasing each year. And finally, I'd like to take you back to the SARS outbreak back in 2003. Remember, this was caused by a one-time mutation event, started in China and spread internationally and was rapidly stopped because the world was willing to work together with a very strong director general at WHO, Gro Harlem Brundtland, who was the former prime minister of Norway, and she was also a pediatrician. She was strong, she got the world to work together, and the outbreak stopped. Now, after the outbreak in China, there was research which was done. Some of that research was in animal farms because they raise their wild animals in animal farms. They have domesticated them, and those wild animals are raised in farms. And in some of those farms, up to 80% of the animals were infected with a coronavirus, not the SARS coronavirus, which was a one-time event, but with some type of coronavirus. And when they looked in communities and in markets, 13% of animal traders in markets and 1 to 3% of people living in the catchment area of those markets had antibody to COVID-19. Now, I would hope in the US, at least this is what I'm sure most of you would do, you would say that is evidence that we need to translate into action. We need to educate animal traders and live market workers. We need to educate the general populations, and we need to develop a vaccine and vaccinate animals at the wild animal farms to prevent them from becoming infected. But this requires working together of the animal, human, and environmental and commercial sectors. And unfortunately, that did not happen in China. What China did was they made it illegal to sell wild animals. I actually had a PhD student, a Chinese PhD student, working in China in the years 2010 to 2011. And she was doing her thesis on looking to see what happened when legislation made it illegal to sell wild animals. And we all know what happened. It just drove that trade underground. And in fact, she went into one community, she told me. She asked the district commissioner in that community, the district commissioner's office in that community, where she could buy wild animals, and they told her exactly where to go. So legislation such as this is easy for political leaders to make. We need to make sure they don't make them. And this would have possibly, if they'd have followed the good public health advice, could have prevented possibly the COVID-19 pandemic. So the final area in health security that we're all concerned with is working together the animal, human, and environmental sectors in what's called a One Health approach. Now, during COVID-19, there was an attempt to make a more equitable distribution of vaccines. This was late. This was after the US and the UK and Europe had already provided vast amounts of money to industry and pulled those vaccines out of out of research and development into licensing and manufacturing. But this was set up with the idea that countries could then, after that, either purchase their vaccines through what's called the COVAX facility, or the donors, such as WHO and UNICEF and others, could also buy their vaccines through the COVAX facility. The COVAX facility wanted to get as many groups, industrialized and developing countries, and donors purchasing their vaccine through the facility so that they could negotiate the best possible price with manufacturers. This did not work very well. They were trying to get money to begin to accumulate vaccines so that countries could either purchase them or the donors could purchase them, but they ended up with a funding gap of 11 billion. But even so, they did manage to get out 1.57 billion doses of vaccines. And there were other parts of the COVAX facility that got out diagnostic tests as well. Now, That makes it clear that health security has many components. It has border requirements, strong public health, a safety net called the FAKE, resilient healthcare, healthy populations, and working together in animal, human, and environmental sectors. We need to get this message across to our political leaders, and this must be underpinned by more equitable access to vaccines, to drugs, and to diagnostic tests, or one country will protect themselves, the others will suffer, and eventually that infection will come back into countries. So health security must be more than just stopping disease at borders. So I was asked to speak a little bit about how to strengthen national security with surveillance for more rapid detection and response. And what I'll go through is some recent digital technologies, which many of you will know about. First is community reporting and alert using handheld devices. And if we can get every community to be reporting regularly to a local area which screens, triages, and then passes onwards and has action locally, there will in fact be a much better detection system than we have at present. You will have used this, some of you, the participatory surveillance of flu near you. This has data collection on a smartphone. People report when they're sick, what they've got, what their symptoms are. There's no laboratory association with this, but it then goes up and there is eventually work to develop laboratory testing in the area where the outbreak is occurring. And the action can be local, regional, and national. The flu near you also prints out where the cases are occurring and gives a good idea of symptoms and permits the system to go back and tell people where to go to get vaccinated or to get treatment. It's collective understanding of influenza at local, regional, and national levels. The future. Many countries are using this to report other things, such as polio in Pakistan, Afghanistan, and many different countries around the world are adapting local systems. Then there's an automatic syndromic surveillance system, which has been developed in the United Kingdom, here in London. And as you know, in the United Kingdom, there's a socialized medicine, universal health coverage through the National Health Service. The National Health Service starts with a telephone call to a line manned by nurses. And there are over 300 clinical algorithms that are used to assess patients based on their symptoms. And then the patient is referred wherever that patient needs to go. Although patients also can go directly to the clinic without going through this triage system. Daily calls are automatically monitored for 10 syndromes, including colds or flu, cough, fever, diarrhea, and vomiting. How does it work? Well, it works because every 24 hours, all the records in the database, in the digital database, are scanned, and then they're portrayed on a barometer such as this. And if it's red, such as the vomiting on this, then in fact, there's an immediate response and investigation to determine what's happening in the area where this is occurring. Baselines have been established. This shows you a cold flu indicator, and it shows you an increase in 1 year. A very important system, which was developed actually just before the Olympics in 2012 to be used in the emergency departments in the areas of the Olympics, but is now spread throughout the country, only possible in a country which has connected digital records. Some of this data can then be mapped, and many of you will know Health Map as well, which is a digital mapping app. You put in your data, it prints out for you or sends out to you where disease is occurring, and it tells you if there are any problems with that data. Then there's closer to patient laboratory testing, which is very possible today as well because of modern technologies, including self-testing with lateral flow tests. And self-testing was very important in many countries in COVID-19. Here in the UK, it was extremely important, and people could use it to gauge whether or not they would go visit elderly relatives or they took their own control in testing themselves and deciding what to do. And this is some of the closer to closer to patient diagnostic facilities that are available. Finally, genomic surveillance and genomic sequencing and environmental surveillance has been very important as well. And that's due for many reasons. One of those reasons being that you can now do a sequence in a handheld device, a mid-ion device, which prints out immediately the genetic sequence. This is important. And just to show you how important it is, I'm showing you the sewerage system in Cairo in Egypt. You can see where there's blind monitoring and there's a risk area. The risk area is an area where there was polio occurring. And the vaccination campaigns had stopped all polio. But remember, for every child with flaccid paralysis from polio, there are up to 500 to 1,000 infections. So it was clear that AFP, flaccid paralysis, was no longer occurring. But by looking in the sewage system, they could find that the wild polio virus, red, actually stopped at the same time that the acute flaccid paralysis was no longer being identified. And all they were finding after that was Sabin polio virus from the vaccine. So environmental surveillance is very important, and it's being used here in the UK and in the US, I know, for many different infections. Here's how it was used for COVID-19. It's the environmental surveillance here in the UK that picked up polio here in London a few years back, and then the US picked it up in the New York surveillance system. So surveillance using surveillance in wastewater using genomics is a very powerful tool. And finally, there are web-based global alert systems, and one of these is the Global Public Health Intelligence Network of Canada, which is screening the web every 24 hours for reports, as you can see here, reports that come from news sites from all around the world. It takes that language, it scans in 7 different languages, takes those reports, processes them, turns it into alert notifications, and sends those alert notifications to WHO for validation every morning. So every 24 hours, Canada sends off to WHO the outcome of its GFIN system. It also sells this outcome to groups in the US and to others to continue to sustain it, but to WHO, it provides that information at no cost. And then there's ProMed Mail, which is the International Society of Infectious Diseases discussion site, where there are moderators around the world, and these are the moderators, who moderate on reports that are coming in from experts who are identifying diseases in their areas. A very important tool on the digital highway. And you can, if you don't have, you can have subscriptions to ProMed Mail, and that gives you an update on what is being reported by health workers and others around the world. And it's some very interesting discussions that go on ProMed Mail. Finally, joint animal environmental surveillance, One Health, very important in the UK. And here's how it works. In the UK, there's a group which is called the Human Animal Infectious Risk Assessment Group, HARES. And you can see the logos at the bottom. Those logos are from the Department of Agriculture, from the veterinary science group, from the environmental groups, from the human health groups. They all meet together once a month, and they look at what's going on in the world, and they put a color code on that for the UK. This shows you Ebola virus in the Democratic Republic of Congo, and the UK felt that this was a yellow, no change, but an alert that was important for the UK to pay attention to. If they find a disease which is red or yellow and they don't have a guideline for it in the UK, they develop a guideline. They then put information out in their Zoonoses newsletter, and if you want to read more about it, you can read about it in the veterinary record in the United Kingdom in an article that's written about One Health in action. And finally, unfortunately, there needs to be surveillance of some non-productive public health measures, such as the anti-vax movement. And you'll remember the article from Andrew Wakefield who associated the vaccine with autism, and I won't make any more comments about that at present. But that article was shown to be inaccurate. It was retracted, but it was too late. And the anti-vax people picked this up, and there's a necessity now to do surveillance for where rumors are occurring. And this shows you how the UK tracks measles outbreaks, and then when they find where they're occurring from the web, they go out, make sure that they're not in any way being interrupted by the anti-vax movement, and they're working with the local authorities to stop the outbreak. This shows you the internet activity. When there's an increase in demand, there's something going wrong. And finally, the last few slides are on deliberate use of human pathogens to cause harm. None of us want this to happen. None of us know whether it will happen, but those who think they know are recommending that we be prepared. So this especially occurred after 2001 in the US when anthrax spores were sent around the country. The US has developed, before this event, but keeps this up to date, what they call Category A biological agents. These are agents that are thought that could be used deliberately to cause harm to humans. Anthrax, botulism, plague, smallpox, tularemia, viral hemorrhagic fevers. In 2006, after the 2001 outbreaks, as you know, the US government set up BARDA. This is set up with defense money to develop vaccines, drugs, and diagnostic tests for those Category A diseases. It provides funding to private sector. Private sector develops, tests those vaccines, and gets them ready for licensing. It's because of BARDA that we have a vaccine for Ebola that can now be used in outbreaks in Africa. This would never have occurred because there's no market in developing countries where Ebola occurs if BARDA had not existed. But there is an Ebola vaccine because of BARDA that's able to be used in outbreaks of Ebola. At the same time, there's a non-replicating smallpox vaccine, which has been used in Mpox around the world. This vaccine would not exist had it not been supported in the industry by BARDA to develop a vaccine for US stockpiling, but also now available within the world. And that monkeypox vaccine or Mpox vaccine has been very effective in containing outbreaks in the US and around the world. So my final thought, you've just seen through BARDA how defense funding has been transferred for defense funding for bioterrorism has been transferred to benefit nationally occurring outbreaks in current present day's economies. We know that surveillance is important to detect deliberately caused infections, so we need good community-based surveillance. We also know that if these goods are developed for defense, they could be useful also in public health. So really, in thinking through the future, public health funding is limited, defense funding is less limited. Is there a way to continue that exchange and use public health or defense money to strengthen public health, not only goods, but possibly in our present day economies? So that's what I've had to say. Thank you for your attention. I'm sorry we couldn't interact because I like to do that, but I'm ready to certainly have some questions if there are any.
Thank you so much, Dr. Heyman. You covered a lot of ground in a very short amount of time. So I'm sure there are questions. I see one in the chat box we can start with, but certainly if there are others on the line that have questions, feel free to put them in the chat box and we can get to them. So this question is from Doreen. She's asking if there's still global reporting happening from the US now that we have pulled out of the World Health Organization. I don't know if that's a question you can answer or not.
I can't answer that question. What is important to understand is that the US is really a very important partner in the world. And hopefully they will find a way to continue reporting diseases. I know that CDC is having difficulties right now. I'm an alumnus. I spent 25 years with CDC. The group that I started with in my EIS class in the 1970s is meeting regularly to see how we can help in making understanding in the US that WHO and international partnership is extremely important. So anything that public health can do in the US is very important for that. Whether or not the US is reporting, I don't know. I can't answer that question. I know that if they do report, their reports will be accepted by WHO.
Another comment here from Jason asking, do you have any concern about the seemingly unchecked spread of chronic wasting disease in deer, elk, moose?
Yeah, I think we should be concerned about any infection in humans. And I know there are surveillance systems in wildlife in some parts of the US. Also, salmon in salmon farms can be have another encephalopathy as well. And so there are many of these that have these encephalopathies which become chronic and can cause infection. I don't know if there have been any humans infected with a spongiform encephalopathy from deer or not, but I know that it's a concern. I think you'll probably know better than me. Maybe someone in the audience could actually answer that question. I don't know.
Any additional questions for Dr. Heyman? All right, well, if you think of any after the fact, you can certainly send them to the APIC Great Lakes team and we can get in touch with Dr. Heyman. But with that, thank you so much for joining us for the wealth of information. And like we shared at the beginning, the slides from this presentation will be available, as will the recording. But before we close our session for today, I just want to do a few very brief APIC Great Lakes updates and reminders. This is a list of all of our upcoming APIC Great Lakes webinars. And you'll see October 9th has been confirmed for our fall conference. More information to come on that. This on the next slide is the save the date, which has gone out today or will be going out. So again, just keep an eye on that and looking forward to seeing everyone again in October. Next, just as a call for those of you who are graphically inclined and sort of more on the design side, as we do every year for APIC National Conference, we are going to do shirts for the chapter. So if you want to design a shirt and submit it, we will ultimately have the chapter vote, and whoever designs the winning logo will get a free shirt. So feel free to submit those. The deadline is March 15th, so kind of quick turnaround there. But if that's something you're interested in, please know that that is something that we are looking for help with. And then as usual, just the reminders about the webinars, everything is posted on our YouTube channel. So if there's something you've missed or want to circle back to, everything is posted there, as are the slides on the website. And lastly, job postings. I know we've really been pushing this, but really trying to encourage folks that have openings for infection prevention positions, email us so we can post them on the job board. And then certainly if you or somebody you know is looking for a job, definitely check that out and see what options are available that you might be interested in. So with that, I will pause just for a couple minutes and see if there are any additional questions. Dr. Heyman, I see a lot of thanks and kudos to you in the chat. So again, thank you so much for joining us, spending some of your evening with us, because I know you're a number of hours ahead of us here in Michigan. And again, thank you for all the information that you shared with us. I think this is really, really helpful.
Thank you for having invited me.